Okay, let's unpack this. Imagine being a surgeon faced with a really critical decision, one that directly impacts a patient's ability to live. Not just survive, but actually thrive, getting the life-sustaining treatment they desperately need.
Hmm.
That's the world of vascular access for hemodialysis. It's a field where precision, planning, and a deep understanding of proven guidelines aren't just good practice. They are quite literally life-saving.
Indeed. And today we're embarking on a deep dive into the European Society for Vascular Surgery's 2018 guidelines on vascular access.
Hmm.
This document is truly a gold standard, a comprehensive roadmap for optimal care.
Right.
Now, to make this particularly impactful for you, our listener, we're going to frame our discussion by simulating a high-stakes scenario, an FRCS Vascular Surgery Part 2 Viva station.
Okay, like a practice exam.
Exactly. Think of it as a rigorous oral exam where every decision, every single nuance, matters deeply in a real patient's life. Our mission today is to walk you through the essential knowledge, the must-knows, and even some maybe surprising facts that guide surgeons in providing the best possible vascular access.
Exactly. You, our curious listener, are going to be right there with us. We're going to dissect a real-world clinical case, exploring how these vital guidelines translate into concrete patient care, from that very first assessment all the way through managing, complex complications. We'll break down the decision-making process, the various options available, and the clever strategies for keeping these crucial lifelines open for years. So get ready for some serious aha moments that show just how intricate and patient-centric this field really is.
Okay, so to set the stage, let's introduce our patient. Imagine you are the surgeon presented with this challenging scenario. A 55-year-old man with end-stage renal disease, ESRD, secondary to diabetic nephropathy, requires permanent vascular access. He has multiple failed upper limb fistulas and currently presents for review. He is right-hand dominant.
Okay, so a 55-year-old with diabetes who's already had multiple prior failures in his upper limbs, and he's right-handed. That immediately raises some significant flags, doesn't it?
It certainly does.
As a surgeon encountering this, what's your very first step in approaching such a complex case?
Well, this patient's history immediately tells us we're dealing with a complex picture, and a systematic preoperative assessment is absolutely paramount.
Right.
If I were the surgeon, I'd begin with a deep dive into his medical history, followed by a thorough physical examination, and then move on to essential imaging. Let's start with history. What critical aspects would you be looking for?
Absolutely. When looking at his history, several areas are non-negotiable. First, his renal prognosis. Understanding that his ESRD stems from diabetic nephropathy is a huge red flag. Diabetes, as we know, can significantly impair a fistula's ability to mature and dramatically increases the risk of failure. We're talking about failure rates that can be nearly half of cases, according to the ESVS guidelines, which isn't just a statistic. It means a significant portion of our diabetic patients are facing repeated procedures and delays in life-saving dialysis.
Yeah, a really high failure rate.
Exactly. We need to know his long-term plans. Is a kidney transplant on the horizon, or is lifelong dialysis the expectation? This profoundly influences the type of vascular access we choose, as autologous AVFs are generally preferred for patients with longer life expectancies.
That's a crucial point about the long-term view. But for this patient, the phrase multiple failed upper limb fistulas really jumps out. How would you unpack that specific part of his history?
That's the core of his challenge, isn't it? I need a detailed history of every single previous attempt. How many, where exactly they were located, what type of access was created. Was it an arteriovenous fistula, AVF, an arteriovenous graft, AVG, or was he relying on central venous catheters, CVCs?
All of those details matter.
For sure. But even more importantly, I need to know the reasons for each failure. Was it thrombosis, meaning the access clotted off? Did it simply fail to mature, never becoming usable? Was there an infection, or did he develop something called Steele syndrome, where the fistula steals too much blood flow from the hand?
Right.
Each of these failure modes points to different underlying anatomical or physiological issues that will dictate our future strategy. And speaking of history, any past central venous catheters are vital to uncover. Every CBC carries a significant risk of causing central vein stenosis, essentially scarring down the large veins in the chest, which could severely limit our future access options, almost like building a roadblock.
You're right, that history of CVCs is often a hidden landmine, isn't it? What other aspects of his medical background would you zero in on?
Beyond his kidney issues and access history, his comorbidities are extremely important. His diabetes mellitus isn't just the cause of his ESRD, it impacts vessel quality throughout his body, often leading to calcification that makes surgical connections tricky.
Yeah, calcified vessels are a challenge.
It also increases his risk of ischemia and nerve damage. Cardiovascular disease is another independent predictor of AVF failure and a major risk factor for that Steele syndrome we just mentioned.
Right.
I'd also check for hypertension, as that can also influence vessel quality. And a hidden risk factor can be any history of thrombophilia or hypercoagulable states, conditions that make his blood more prone to clotting, obviously a huge problem for any vascular access.
Absolutely. Anything that increases clotting risk.
Exactly. Finally, his hand dominance. He's right-hand dominant, so ideally, we want to preserve that arm for daily activities. That means the non-dominant arm is usually our first choice.
Usually, yes.
However, with multiple failed upper limb fistulas, we might have already exhausted those options, forcing us to consider more complex choices, or even needing to use his dominant arm. We'd also review his medication history, specifically looking for antiplatelets, anticoagulants, or any nephrotoxic drugs that might complicate surgery or healing.
That's a truly comprehensive approach to the history. Now let's pivot to the physical examination. What specific aspects would you meticulously assess, particularly with his complex background in mind?
The physical exam is where the detective work really comes alive. I'd start with a general assessment of his overall health, checking for signs of malnutrition or fluid overload, which can impact how he heals.
Good starting point.
Then I'd move to a meticulous examination of both upper extremities, starting with the non-dominant arm, but knowing his history means I'll likely be assessing the dominant arm just as closely from the start.
Makes sense.
For inspection, I'd look for any scars from previous access attempts. Signs of swelling or venous hypertension, that's when you see prominent, sometimes bulging, collateral veins, which can hint at central vein blockage.
Those collaterals are a key sign.
Definitely. I'd also check for skin changes and note any existing CVCs or pacemakers, which, as we know, are critical clues to potential central venous issues.
Right.
Palpation is absolutely crucial. I would systematically feel for his arterial pulses, radial, ulnar, and brachial, assessing their strength and patency. I'd also carefully palpate for any arterial calcification. Feeling those hardened vessels can tell me that connecting a fistula might be technically challenging.
Yeah, that tactile feedback is important.
For the superficial veins, the cephalic, basilic, and median cubital, I'd assess their size, compressibility, and identify any sclerosed, hardened segments from prior cannulations. To get the most accurate picture of his veins, this should ideally be done in a warm room, often with a tourniquet applied proximally to maximize vasodilation.
Maximize those veins, yeah.
The guidelines give us a clear target. For a successful wrist fistula, we're looking for a radial artery and cephalic vein with a minimum internal diameter of 2.0 millimeters. And for elbow-level fistulas, both the artery and vein should ideally be at least 3 millimeter. I'd be feeling for those critical dimensions.
Those numbers are key, 2 millimeters and 3 millimeter.
Exactly. Finally, auscultation involves listening for bruits over any existing or proposed access sites. A detailed assessment of distal perfusion is also essential, checking capillary refill, skin temperature, and the strength of digital pulses.
Especially important for proximal AVFs.
Incredibly important, yes, or if there's any suspicion he might already have a touch of Steele syndrome. And lastly, I would always examine the central veins, looking for any swelling in the arm or face or prominent chest wall veins, which could be telltale signs of central venous obstruction.
That thorough physical exam gives you a solid clinical picture. Now, how do you translate that into objective data? What about imaging? What modalities are essential for preoperative planning in this patient, and what specific information are you seeking from them?
For imaging, duplex ultrasound, DUS, is unequivocally the gold standard and my first-line modality. The guidelines strongly recommend it for all patients because its purpose is preoperative vein mapping.
Can't stress that enough. DUS for everyone.
It gives us a precise evaluation of vessel depth and helps detect those crucial vessel segments that might be missed by physical examination alone. You know, sometimes a radial pulse feels fine clinically, but DUS can reveal underlying arterial issues that would doom a fistula.
Right. Catches things the fingers miss.
For arterial assessment, DUS allows us to measure diameter, blood flow characteristics, and crucially identify any stenotic or narrowed segments. For example, it's shown that in a significant percentage of patients, DUS can identify inadequate arterial inflow that wouldn't be apparent on a simple pulse check, directly impacting where we might create a fistula.
So it guides the location choice.
Precisely. On the venous side, DUS is equally vital. It provides those critical internal diameters, remember the 2.0 millimeter and 3 millimeter parameters we just discussed, and helps us identify any venous lesions like previous thrombosis or scarring. It also measures the depth of the vein from the skin, which is paramount for future cannulation. If a vein is deeper than about 0.6 centimeters, it can be extremely difficult to needle consistently for dialysis.
Depth is crucial for the dialysis nurses.
Absolutely. DUS can also provide insights into blood flow volume, which can help us predict the risk of early failure. The clinical significance of DUS really can't be overstated. Studies have shown a dramatically lower primary failure rate for fistulas when preoperative DUS is used, essentially stacking the odds in the patient's favor.
That makes the role of DUS crystal clear. What about other imaging modalities? When do they come into play, especially for a patient with his complex history?
Yeah, good question. Other imaging modalities are typically reserved for selected, more complex cases where DUS alone isn't enough. Digital subtraction angiography, DSA for instance, is helpful in patients with significant peripheral vascular disease and suspected blockages in the arteries closer to the heart.
Proximal arterial issues, yeah.
Sure.
Or for a very clear picture of central veins, where it's superior to DOS for central venous occlusive disease. However, it's generally reserved for situations where we anticipate needing to intervene immediately after the diagnosis, avoiding routine diagnostic angiography due to its invasiveness and the use of contrast dye.
Intervention planned, then maybe DSA.
Right. Computed tomography angiography, CTA, is another option. It's less invasive than DSA and provides excellent information for detecting significant stenoses or complete blockages, especially in dysfunctional fistulas. It's particularly useful if DOS results for central venous stenosis are inconclusive.
CPA for central veins if DOS isn't clear.
Exactly. The trade-off, of course, is that it also uses iodinated contrast and involves radiation exposure.
Always a balance.
Then there's magnetic resonance angiography, MRA. This one has a critical caveat. Contrast-enhanced MRA, CE-MRA, is explicitly not recommended in ESRD patients because of a severe risk called nephrogenic systemic fibrosis, NSF, a debilitating condition.
The warning there, no CE-MRA.
This is a very strong recommendation from the guidelines, a definite contraindication. However, non-contrast enhanced MRA, NCE-MRA, is an evolving technology that looks very promising for preoperative visualization and postoperative evaluation because it avoids that NSF risk altogether.
NC-MRA might be useful in the future then.
Potentially, yeah. Finally, for our patient, with his history of previous central venous catheters, it's absolutely essential that we get central venous imaging, such as venography or intravascular ultrasound, to definitively rule out any existing central venous obstruction. This is crucial because a blocked central vein can render even a perfectly created upper arm fistula useless.
Gotta know the outflow path is clear.
Wow, that really puts into perspective how comprehensive this assessment is. It's not just about finding a vein, it's about finding the right vein and artery and mapping out the entire vascular tree, isn't it? It truly feels like detective work.
It really does.
For our listener, understanding this meticulous process highlights why early referral to a specialist team is so incredibly crucial, giving us the best chance to plan effectively.
Indeed. Now, considering our patient's history of multiple failed upper limb fistulas, we've established the need for a thorough workup. But what about the primary vascular access options themselves? How do you think through the choices, moving from the ideal distal to proximal approach, and then addressing secondary and even tertiary choices when the conventional paths are exhausted?
Yeah, given our patient's challenging history, the conversation around access options shifts dramatically. We always adhere to the fistula first, graft second, line last principle.
The mantra, yeah.
Which prioritizes autologous AVFs due to their lower complication rates and fewer revisions compared to grafts or catheters. It's the gold standard for a reason. However, for a patient with multiple failed upper limb fistulas, the standard distal to proximal strategy becomes far more complex. We still try to preserve as many vessels as possible for future access, but the realistic options definitely narrow. Let's break down the autologous arteriovenous fistula, AVF, the gold standard. First, the radiocephalic AVF, RCAVF, at the wrist, often called a seminofistula, is the initial first choice when possible. But honestly, for a patient with multiple failed upper limb fistulas, it's highly unlikely we'll find suitable vessels here.
Probably used up already.
Very likely. For successful creation, the radial artery and cephalic vein typically need a minimum diameter of 2.0 millimeter with a tourniquet. Even when possible, these distal fistulas can have high early failure rates, especially in elderly patients with comorbidities like our diabetic patient.
Right, the failure rates can be sobering.
If an RCAVF isn't feasible or has already failed, the brachiocephalic AVF, BCAVF, at the elbow is the next preferred option. This one needs minimum arterial and venous diameters of 3 millimeter. While it provides excellent access flow, which is ideal for efficient dialysis,
Good flow, yeah.
it does carry a slightly higher risk of reduced distal perfusion in the hand, or even, in rare cases, cardiac overload if the flow is extremely high. Still, it generally boasts good one-year patencies and lower rates of thrombosis and infection compared to grafts.
So a good option if the wrist isn't possible.
Yes. Beyond that, the brachiobasilic AVF, BBAVF, in the upper arm becomes a strong consideration. This often requires a staged transposition, meaning we relocate the deeper basilic vein to a more superficial position, making it easier to cannulate.
That transposition is key for the basilic vein.
It really is. Meta-analyses show these BBAVFs are generally preferred over synthetic grafts, offering better long-term patency rates and fewer reinterventions. This is a vital option when other upper arm AVFs have been exhausted. There are also other less common upper arm options like mid-forearm fistulas or those involving deeper perforating veins.
Lots of variations.
It's crucial to remember that patient-specific variables like age and diabetes significantly influence both maturation and overall failure risk, as does vessel size, for instance. Women can sometimes have smaller vessels.
That's a clear progression through the autologous options. But what if, despite all that meticulous assessment, autogenous AVFs are truly exhausted for this patient? What prosthetic options or arteriovenous grafts would you consider next, following the graft second principle?
Right. If autogenous AVF creation is genuinely impossible, that's when we turn to prosthetic options, specifically arteriovenous grafts or AVGs. Expanded polytetrafluoroethylene, EPTFE, is the most common type, though there are other materials available.
PTFE is the workhorse.
It is. AVGs do offer reasonable short-term patency. Their primary patency, meaning they stay open without intervention, is typically around 40–50% at 1 year.
Not great primary patency.
No, but their secondary patency, meaning they can be salvaged with interventions to keep them open, is higher, often 70–90% at 1 year. But this clearly comes at the understanding that they will likely require multiple procedures to maintain that patency.
Lots of upkeep needed.
Definitely. A significant advantage of AVGs is the possibility of earlier cannulation, usually 2–4 weeks post-creation, or even as early as 24–72 hours for early stick grafts.
That's a big plus, avoiding the line.
It's a huge benefit because it helps patients avoid prolonged reliance on central venous catheters, which carry many risks. In fact, elderly patients who sometimes have more fragile vessels or higher AVF failure rates may specifically benefit from AVGs as a primary choice.
So early cannulation is a plus. But what are the trade-offs, the disadvantages of these prosthetic grafts?
The disadvantages are significant and need to be weighed carefully. AVGs have substantially higher rates of thrombosis, often due to a process called neo-intimal proliferation at the venous connection.
That dreaded neo-intimal hyperplasia.
Where the body tries to heal around the foreign material, leading to narrowing. They also have markedly higher infection rates. We're talking 4–20% compared to a much lower 0.55% for native AVFs.
Much higher infection risk.
And because of these issues, they inevitably necessitate more frequent reinterventions to keep them functioning. It's important to note that for patients with particularly challenging central venous access who need early hemodialysis, the guidelines do recommend considering self-sealing grafts, which can be cannulated even sooner.
You've addressed AVFs and AVGs.
Yeah.
Now, what about central venous catheters, CVCs? What's their role in this patient's long-term access plan, especially considering that critical line last principle?
Central venous catheters, or CVCs, are truly the line-last option for a very good reason. Their use for long-term access is generally discouraged due to significantly higher morbidity and even mortality.
Really the last resort.
Absolutely. There are two main types: non-tunneled CVCs, NT-CVC, for temporary use, typically less than 2 weeks, and tunneled cuffed CVCs, TC-CVC, for longer-term access.
Tunneled lines for longer use.
Yeah. The indications for a permanent TC-CVC are quite specific and limited. They might be considered in patients with severe fistula-induced limb ischemia, unmanageable cardiac failure due to high fistula flow, or those with a very limited life expectancy where creating and maturing a fistula isn't practical.
Specific situations only.
Right. They're also used as a bridge for patients experiencing peritonitis from peritoneal dialysis or those who are imminently awaiting a planned kidney transplant. The right internal jugular vein is always the preferred location for CVC insertion due to lower complication rates.
Right idea is best.
Alternatives include the left jugular, femoral, and subclavian veins, but femoral and especially subclavian CDCs should only be used for very short periods because of their increased risk of infection and, critically, central venous occlusive disease.
Avoid subclavian if possible.
Studies clearly show significantly worse survival rates for patients relying on CVCs compared to those with AVX or ABGs, largely because CVCs carry the highest risk of hospitalization due to access-related infections.
Given our patient's history of multiple failed upper limb fistulas, it's highly likely that standard upper extremity options might be exhausted. This is where the complexity truly arises. What about special or tertiary vascular access options for patients like ours who have run out of conventional sites?
This is indeed where the case becomes exceptionally challenging, and we move into the realm of tertiary vascular access, truly pushing the boundaries. These options are typically reserved for patients who have exhausted all conventional upper extremity sites, or those with bilateral central venous occlusive disease, which, as you pointed out, is precisely our patient's dire situation.
Running out of road, basically.
Pretty much. First, lower extremity vascular access. The primary options here include autogenous great saphenous vein, GSV, or femoral vein, FV transpositions, or the implantation of prosthetic grafts, such as thigh grafts.
Thigh grafts or vein transpositions in the leg.
While these can offer acceptable patency rates, they come with increased risks. For instance, there's a higher risk of ischemia in the lower limb and a significantly higher infection risk, particularly for prosthetic grafts in the lower limb.
Higher risks in the leg.
The guidelines are very clear on this. Lower extremity vascular access should be considered only when upper extremity access is absolutely impossible. Furthermore, within the lower limb, femoral vein transpositions are generally preferred over prosthetic grafts due to better primary patency and lower infection rates.
So vein transposition is better than a graft in the thigh.
Generally, yes. Then there's the HERO graft, which stands for Haemodialysis Reliable Outflow Device. This is a fascinating hybrid. It combines a standard EPTFE graft that's connected to an artery, but then it transitions into a nitinol-reinforced silicone catheter.
The hybrid device.
This catheter is designed to tunnel through central vein lesions and then extend all the way into the right atrium, essentially bypassing those central obstructions. Its primary indication is as a truly useful alternative to CVCs in patients who have inadequate upper limb veins and significant central venous obstruction, like our patient.
For central vein blockage, specifically.
Right. While it's innovative, its primary patency isn't exceptionally high, but it offers a much better secondary patency after interventions. Here's where it gets interesting and a bit surprising. A significant complication with the HERO graft is a relatively high incidence of Steele syndrome, reported as high as 24%.
Wow, 24% Steele, that's high.
And notably, it's often observed in women. This means while it solves the central vein problem, it can introduce new challenges for distal limb perfusion, so it's not a silver bullet, but a very specific tool.
That's a really important nuance about the HERO graft's Steele rate. And what about the absolute last resorts for those patients who have truly exhausted every other option?
For the most extreme cases, when patients have absolutely exhausted all other sites, we look at complex or unusual access options, such as grafts that span the diaphragm or arterial loops. These are truly reserved for end-stage vascular access patients.
Really end-stage stuff.
These procedures are highly complex, carry significant risks of infection, and sadly, higher mortality. Examples include axilloiliac or axillofemoral grafts or axilloaxillary loops. These are absolute last resort measures undertaken when there are no other viable options to provide life-sustaining dialysis.
Huge operations with big risks.
This is where it gets really interesting, isn't it? For a patient who's had multiple failures, the conversation shifts dramatically. It's no longer just about fistula first, but about what's next, what's viable, and weighing those incredibly complex risks.
The decision-making gets very tough.
The fact that the HERO graft, while innovative and a lifeline for some, has such a surprisingly high Steele rate, especially in women, is a critical detail for patient selection and managing expectations. It's truly not a one-size-fits-all solution.
That's a perfect segue. Building on our discussion of options and their complexities, what are the overarching ESVS principles and recommendations that guide the entire process of vascular access creation and planning? This provides the blueprint for best practice, especially in a challenging case like ours.
The ESVS guidelines truly provide a clear roadmap, even for complex patients like ours, and they emphasize foresight and patient safety. Let's break down some of the most critical principles that guide us.
Okay.
First, and foundational, is the hierarchy we've already mentioned. Fistula first, graft second, line last. This isn't just a catchy phrase, it's the cornerstone of care, firmly advocating for autogenous AVFs due to their significantly lower morbidity and mortality.
Reinforces that AVF preference.
Catheters, in particular, lead to dramatically higher hospitalization rates for infection, underscoring why we strive to avoid them whenever possible for long-term access.
So the preference for AVFs is a clear priority. What about the timing of patient referral to a surgeon? How early is early enough?
That brings us to our second principle, early referral and planning. The guidelines strongly recommend that patients with end-stage renal disease are referred to both a nephrologist and a surgeon well in advance of needing dialysis.
Plan ahead.
Exactly. The goal here is twofold: to minimize the urgent, unplanned use of central venous catheters and to give us time for interventions that can delay renal damage, time to correct underlying health issues, time to discuss all renal replacement therapy options with the patient, and crucial time for their psychological preparation for dialysis.
That planning time is vital.
The guidelines are clear. The time from referral to vascular access creation should be as short as practically possible. This principle also highlights that the surgeon's knowledge and experience truly impact outcomes. They even recommend that training programs ensure new surgeons supervise a significant number of AVFs to build this expertise.
Experience counts.
That makes sense. Knowing the landscape early allows for better strategy. And speaking of strategy, you mentioned imaging earlier. How integral is it to the planning process according to the guidelines?
Absolutely integral. That leads to our third key principle: preoperative duplex assessment. The guidelines consider preoperative ultrasound of both upper extremity arteries and veins as standard practice for all patients.
Standard of care, really?
Its rationale is powerful. It significantly enhances the success of AVF creation and improves overall outcomes by detecting inadequate vessels or hidden stenotic segment that a physical exam might miss. It's how we confirm those critical minimum diameters, like the 2-point urometer for a wrist fistula or 3 millimeter for an elbow fistula, setting the stage for success.
So early assessment and the right tools. What about the long-term vision for the patient?
That's our fourth principle, the long-term goal. The guidelines recommend we aim for autologous AVF if the patient's life expectancy is estimated to be greater than 1 year, assuming, of course, that their vessels are suitable.
Matching the access to the prognosis.
This emphasizes the durable benefit of AVFs over other access types for patients who will rely on dialysis for an extended period. Fifth, a common-sense principle, but vital for patient function. Use the non-dominant arm preferentially. This is done to preserve the function of the dominant limb for daily activities. However, as we discuss with our patient, a history of multiple failures might necessitate overriding this preference.
Sometimes you don't have a choice.
Sixth, a crucial warning: avoid subclavian lines. This is due to their notoriously high risk of causing central vein stenosis. Femoral and subclavian central lines should only be used for very short periods, as they can permanently jeopardize future access.
It seems like every decision, even minor ones like where to put an IV, can have long-lasting consequences for these patients. Is that right?
Exactly. And that brings us to our seventh principle: venous preservation. It's essential to diligently preserve forearm veins in any patient at risk of chronic kidney disease. This means actively avoiding intravenous cannulae and venipuncture in the crucial cephalic, basilic, or antecubital veins.
Protect those veins.
If an IV or blood draw is absolutely unavoidable, the dorsum of the hand should be used instead. It's like saving real estate for a future home. Every usable vein counts as a potential lifeline.
A good analogy.
Eighth, a simple but effective measure: preoperative hydration. Considering adequate hydration before surgery is recommended because it has been shown to improve the primary patency of AVFs, particularly in patients whose vessels are borderline in size.
Simple, but can help.
Ninth, prophylactic antibiotics. These are recommended specifically for prosthetic AVG insertion. We use a broad-spectrum antibiotic, particularly one targeting Staphylococcus aureus, which is a common culprit in infection.
Especially for grafts.
For patients who are MRSA carriers or in units with a high incidence of MRSA, specific parenteral glycopeptides like vancomycin are recommended.
Okay.
10th, preoperative antiplatelet agents. While the evidence is still evolving, aspirin or another antiplatelet agent given preoperatively and continued postoperatively may help reduce the risk of the fistula clotting off.
Still some debate there.
11th, anesthesia. Regional anesthesia, such as an axillary or brachial block, may be preferred over local anesthesia. This isn't just about pain control. There's a possible improvement in access patency rates linked to the significant vasodilation that regional blocks can induce.
Regional block might improve flow. Interesting.
12th, AVF configuration and surgical technique. The guidelines prefer an end-to-side anastomosis, where the vein is connected to the side of the artery. And critically, the AVF should be performed at the most distal site possible to preserve vessels further up the arm for future use.
Start distal, preserve proximal.
While more proximal AVFs can have lower initial failure rates, they carry a greater risk of fistula-induced limb ischemia and can be harder for dialysis nurses to cannulate. Also, if a patient has a pacemaker or a central venous catheter, the contralateral arm is preferred for access creation due to the ongoing risk of central venous stenosis.
Avoid the side with the pacemaker line.
13th, a practical consideration for a growing patient population: obesity. For obese patients, veins can be deeper than 0.6 centimeters, making them very difficult to cannulate. In these cases, superficialization or transposition of the vein is often required.
Dealing with deep veins.
Other alternatives like liposuction or even titanium venous windows can be considered to bring the vein closer to the surface.
Right.
Finally, perioperative anticoagulation. Systemic heparinization during the procedure generally doesn't improve patency and actually increases the risk of postoperative bleeding. So it should generally be avoided unless the use of a tourniquet for hemostasis effectively neutralizes the bleeding risk.
So what does this all mean for you, our listener? It means even with a challenging patient like ours, the ESVS guidelines provide a clear roadmap. They emphasize foresight, the absolute importance of detailed imaging, and a proactive, multidisciplinary approach right from the start. It's not just about the surgery itself, but literally everything leading up to it and the long-term patient journey that determines success.
Indeed. Now, our patient has a history of multiple failed fistulas, and managing complications is arguably where the true art and science of vascular access lies. Let's delve into this critical area. What are the common early and late complications of vascular access, and how would you approach their management, specifically addressing those relevant to a patient with failed previous access?
Complications are an unfortunate reality in vascular access, and for a patient with multiple previous failures, the likelihood of encountering them again is certainly elevated. We generally categorize them into early and late complications based on their timing.
Okay, early first.
Let's start with early complications, which occur within the first 30 days after creation. These are often critical and demand immediate attention. First, hemorrhage. Dialysis patients frequently have an increased bleeding tendency.
Bleeding risk is higher.
This is why we ideally schedule elective procedures between dialysis sessions to minimize any residual effects of heparin. Management typically involves direct compression. If bleeding persists or is significant, we're talking about surgical revision and possibly evacuating any hematoma to prevent further issues like infection or skin necrosis.
And what about infection, particularly concerning early complications?
Early postoperative infection is thankfully low for autogenous AVFs, typically around 0.8%, but when it happens, it's severe.
Low, but serious.
For AVF infections without an abscess, pseudoaneurysm, or ongoing hemorrhage, a course of antibiotics, often for 6 weeks, is recommended. However, if there are systemic signs of infection, significant bleeding, or if the infection involves the anastomosis, that crucial connection point ligation of the AVF is necessary to prevent a life-threatening systemic infection.
Ligation, if it's systemic or involves the anastomosis.
Right. For prosthetic AVGs, on the other hand, early infections usually involve the entire graft, which almost always necessitates total graft excision. In these cases, ligating the brachial artery, if needed, is often well tolerated.
Graft usually needs to come out entirely if infected early.
That distinction between AVF and AVG infection management is really important. What other early complications might pop up?
Another one is early onset vascular access induced limb ischemia, VLI, or Steele syndrome. This occurs in a small percentage of proximal AVL procedures, and it often presents immediately.
Steele syndrome, right away.
It's diagnosed by telltale signs: the absence of a radial pulse in the wrist, a pale or cool hand, sluggish capillary refill, or low digital blood pressures. Crucially, if you temporarily compress the fistula, the hand symptoms should improve.
The compression test is key.
Immediate surgical correction is needed. For severe symptoms, or if it's progressing to actual nerve damage, urgent ligation of the AVS is the priority to prevent tissue loss or permanent neurological damage. Less severe cases might involve flow-reducing procedures, which are basically surgical techniques to redirect some of the blood flow back to the hand.
Ligate if severe, or revise if less so.
Then there's ischemic monomelic neuropathy, IMN. This is rare but extremely severe. It's caused by a lack of oxygen to the peripheral nerves, leading to pain with sensory or motor deficits that are out of proportion to the visible signs of ischemia.
Pain out of proportion.
If IMN is suspected, prompt AVF ligation is required to prevent permanent neurological damage. We specifically monitor for this in patients with diabetes or pre-existing neuropathy.
Must ligate for IMN.
And of course, thrombosis.
Exactly. Early thrombosis is the most frequent complication within the first 30 days. It's often due to technical errors during surgery, low blood pressure, or a patient's underlying tendency to clot, or even an undetected narrowing in a vein upstream.
Most common early problem.
Treatment requires urgent thrombectomy, removing the clot and revision of the fistula if an underlying stenosis is found. This needs to happen as soon as possible, ideally within 7 days. Here's a critical point. Thrombolysis, which is dissolving the clot with medication, is not recommended within 7 days of creation because of a high bleeding risk.
No early thrombolysis. Thrombectomy.
And for long-term patency, we must identify and treat any underlying narrowing that caused the clot in the first place.
Fix the underlying cause.
Finally, for early complications, non-maturation of AVF or failure to mature. This happens when the fistula simply doesn't develop enough in size or flow to be usable for dialysis. Rates can be as high as 33% for wrist fistulas.
Failure to mature is common, especially at the wrist.
Risk factors include being female, older age, distal placements, and small vessel diameters. We diagnose it with a physical exam and duplex ultrasound, looking for what we call the rule of sixes. A vein diameter of more than 6 millimeters, blood flow over 600 millimeters, and sitting less than 6 millimeters from the skin surface, making it easy to needle.
The rule of sixes: 6, 600, 6.
If a fistula isn't maturing by 6 weeks, we investigate further, usually with more DUS, to find the cause, such as a hidden stenosis or a competing vein. Management involves salvage procedures like ligating a side branch, making the vein more superficial, or performing angioplasty to open a narrowed segment.
Try to salvage it if possible. That's a thorough breakdown of the immediate challenges. Now let's shift focus to late complications, which can emerge months or even years down the line. What are these and how do you approach their management, particularly for our patient who has had a long and complex history with his access?
Late complications represent the long-term challenges of vascular access, and for our patient, these are particularly relevant given his history. Let's start with true and false access aneurysms.
Aneurysms, yeah.
True aneurysms in AVFs are localized balloon-like dilations of the vein, often due to repeat needling in the same area during dialysis, or downstream narrowing. They carry risks of thinning skin over them, infection, and rupture.
Risk of rupture is serious.
False aneurysms, more common in AVGs, are defects in the graft wall, often at the connection site. We diagnose these clinically and confirm with duplex ultrasound. Management primarily involves surgical revision, trying to preserve cannulation sites where possible, which might mean reshaping the aneurysm, resecting a section, or bypassing it with a new piece of graft.
Surgical repair is often needed.
It's crucial not to cannulate pseudoaneurysms for dialysis. Sometimes stent grafts can be an option, and we must always rule out and treat any outflow stenosis that might be contributing to the aneurysm's growth.
Don't stick the pseudoaneurysm and check the outflow. And infection, a persistent threat.
Absolutely. Infection remains a major cause of morbidity and mortality. CVCs carry the highest risk, followed by AVGs, then AVFs. Risk factors include the patient's underlying conditions like uremia and diabetes, comorbidities, previous CVC use, and repeated cannulation.
Lines are highest risk, then grafts, then fistulas.
Gram-positive bacteria, like Staphylococcus aureus, are the predominant culprits. Treatment starts with broad-spectrum antibiotics, then targeted ones once we know the specific bug. For AVFs, we try to avoid cannulating the infected site, and if the infection involves the anastomosis, surgical resection might be necessary.
Treat AVF infection with antibiotics usually.
But for infected AVGs, total graft excision is often recommended for sepsis or surrounding fluid collections. Sometimes partial excision can be considered for localized infections, but conservative treatment with antibiotics alone is rarely sufficient for a graft infection. This distinction in management between infected fistulas and grafts is critical.
Infected graft usually means excision. Big difference. It sounds like a constant battle against narrowing. Tell us about stenosis and recurrent stenosis.
It truly is. Stenosis and recurrent stenosis can occur at any level, where the artery connects within the fistula itself, in the venous outflow, or within the graft. The key here is that we don't preemptively treat every single narrowing. We only intervene if it's hemodynamically significant.
Only treat significant stenosis.
Meaning it's causing a major reduction in blood flow, and it's associated with dysfunction during dialysis.
Right.
Inflow arterial stenosis is common in older patients or diabetics. Percutaneous transluminal angioplasty, PTA, using a balloon to open the narrowing is a safe and effective primary treatment. Stenting might be needed if the vessel recoils or if the narrowing quickly recurs.
BTA first for inflow stenosis.
Juxtaanastomotic stenosis is frequent right at the connection point or in the first few centimeters of the vein graft. PTA is the primary approach, but recurrence rates can be higher than with surgery. Sometimes surgically relocating the anastomosis further up the forearm can be considered.
PTA again, but high recurrence near the joint.
Venous outflow stenosis is suspected if there's reduced flow during dialysis, prolonged bleeding after needle removal, or elevated venous pressures. Again, PTA is the first option, with stents or open surgery if PTA fails repeatedly.
PTA first for outflow, too.
A particularly notorious spot is cephalic arch stenosis, very common in upper arm AVFs. This one often responds poorly to PTA alone. In fact, studies have shown that stent grafts are superior to PTA for recurrent stenosis in this location. Newer technologies like drug-eluting balloons are also being investigated here.
Cephalic arch is tough. Stent grafts might be better there? And if those stenoses aren't caught or treated, what's the ultimate consequence?
Ultimately, thrombosis clotting off is often the final complication of a progressive stenosis. Low blood pressure can also be a contributing factor.
The end results of stenosis.
For AVFs, urgent treatment is needed to salvage them. For AVGs, it's slightly less urgent, but still needs attention. Treatment involves thrombectomy and revision if an underlying stenosis is found, and this should be done as soon as possible. Both surgical and endovascular methods have comparable results for grafts.
Treat thrombosis quickly.
Another major long-term issue, especially for our patient given his history of CVCs, is central venous occlusive disease, CVOD. Its incidence varies widely, but is strongly associated with prior subclavian CVC use.
CVO, the legacy of central lines.
Symptoms can range from being completely asymptomatic to severe arm, face, or even breast swelling, increased resistance in the vein, and ultimately loss of the vascular access. Diagnosis is usually by fistulography or CTA, as a DUS is less reliable for central veins.
Need angio or CTA for central veins.
For symptomatic CVOD, PTA is the accepted primary treatment, but unfortunately, long-term patency is often poor due to the vessel recoiling or narrowing again. Stents or stent grafts can be considered for recoil or recurrence, and for failed endovascular attempts, surgical revision, like a bypass, might be needed.
PTA for CVO, but often needs more, like stents or surgery.
Sometimes extrinsic compression of the subclavian vein, known as hemodialysis-associated venous thoracic outlet syndrome, doesn't respond well to balloons or stents, and the treatment of choice is surgical decompression, like removing a first rib.
Thoracic outlet needs surgery, not just PTAtions. That's a lot to consider. What about issues related to flow that might affect the patient's heart?
Good point. We also watch for high-flow vascular access, high-output cardiac failure. If the fistula or graft flow exceeds 1,500 millimins and the patient develops symptoms like heart failure, we consider flow-reducing procedures.
Too much flow can strain the heart.
These are surgical techniques like banding, which essentially narrows the fistula, or other bypasses designed to reduce the high blood flow and rebalance the circulation.
Banding or revision to reduce flow.
Finally, an important aspect is non-used vascular access. If a patient receives a successful kidney transplant, we actually don't routinely close their functioning vascular access. It's kept as a backup.
Keep the access after transplant, usually.
Closure is only considered for specific reasons, such as refractory heart failure due to very high flow, other severe complications, or sometimes for cosmetic reasons. It's worth noting that non-used AVGs, even if they've thrombosed, still carry a high infection risk and often need to be removed.
Close it only if causing problems. Remove old graft.
This section really hammers home the message that vascular access management is a marathon, not a sprint. From the immediate aftermath of surgery to years down the line, constant vigilance and a readiness to intervene are absolutely essential.
It's ongoing care.
And the nuance between managing an infected NVF versus an infected AVG, where one might respond to antibiotics and the other often requires complete removal, is a key takeaway for anyone caring for these patients.
That's a perfect lead-in. Given this propensity for complications, how do you approach surveillance and salvage for vascular accesses? And what vital role do different members of the healthcare team play in ensuring these lifelines stay open for as long as possible?
Maintaining access longevity is truly a continuous collaborative process involving constant monitoring and strategic surveillance, with the entire healthcare team playing a vital role. First, let's distinguish between monitoring versus surveillance.
Okay, what's the difference?
Monitoring refers to the daily examination of the access by physical signs inspection, palpation for the thrill and bruit, and auscultation. This is done before every hemodialysis session to detect dysfunction before the access actually fails. It's the frontline assessment.
Monitoring is the daily checkup by the nurse.
Right. Surveillance, on the other hand, involves periodic, proactive evaluation using hemodynamic tests, like duplex ultrasound or flow measurements, to detect correctable lesions and prevent thrombosis. This can happen during or outside of HD sessions.
Surveillance is the planned testing, like DUS flow.
So monitoring is daily, surveillance is periodic with specific tests. What about the very initial phase after creation? How do we assess if an AVF is actually ready for use?
That's the crucial phase of maturation and functionality of an AVF. After creation, an AVF needs time to mature, meaning the vein needs to enlarge and its walls need to thicken. We assess this through physical examination, looking for an adequate vein diameter, a soft, compressible vein, and a continuous, strong bruit.
Feeling and listening.
A post-operative ultrasound between 6 to 8 weeks and then again between 2 to 4 months is also very helpful. The rule of sixes is a commonly cited guideline for maturity. We're looking for a vein that's at least 6 millimeters in diameter with a blood flow of over 600 milliliters per minute and sitting less than 6 millimeters from the skin surface, making it easy to cannulate.
The rule of sixes again, key metric.
AVFs are generally considered ready for cannulation 4 to 6 weeks after creation, and typically not before 2 weeks. Standard AVGs can usually be cannulated earlier, after 2 to 4 weeks.
4-6 weeks for AVF, 2-4 for AVG, roughly.
And what can patients do to help that maturation process along?
That's a great question because patients have a role too. Arm exercises, simple hand and arm exercises after AVF creation, are actually significantly recommended because they can notably increase the clinical maturation rate, especially in those distal fistulas.
Squeezing a ball helps.
Exactly. However, it's also important to note that long-term antithrombotic therapy, like blood thinners, is generally not recommended solely to prolong patency. The evidence for its benefit simply isn't there. If an AVF fails to mature by 6 weeks, further investigation, like DUS, is definitely indicated for prompt diagnosis and potential salvage.
Exercise is good, routine blood thinners not proven. Investigate if not mature by 6 weeks. So once the access is mature and ready, what about the day-to-day care? Cannulation techniques and access care are essential for preventing complications, aren't they?
Absolutely fundamental. Strict aseptic technique is paramount for all cannulations. It's the simplest way to prevent infection.
Clean technique always.
A physical examination of the access before every single HD session is also recommended. This isn't just routine, it's how nurses detect early signs of stenosis, like a pulsatile AVF, which can indicate a narrowing downstream.
Examine before every cannulation.
Needle selection is also key. Choosing the appropriate gauge based on vein size and desired flow, with a smaller 17-gauge needle often used for initial attempts. For particularly difficult AVFs, ultrasound-assisted cannulation can significantly improve success rates.
Right, needle size, maybe US guidance.
Regarding specific cannulation methods, the rope ladder technique is widely recommended. It involves using the entire length of the cannulation segment with new sites for each session, ideally about 5 centimeters apart, avoiding previous sites.
Rope ladder spreads out the sticks. Best for grafts.
This technique is especially important for AVGs to prevent disintegration and pseudoaneurysms, literally allowing the graft to heal between sessions.
Right.
The buttonhole technique involves repeated cannulation at the exact same site and angle, forming a tissue tunnel that allows for blunt needles. It may be appropriate for short cannulation segments.
Buttonhole uses the same spot.
But it's crucial to understand that studies have reported an increased infection risk if aseptic technique or scab removal is inadequate. This method is not used for AVGs.
Higher infection risk if not done perfectly. No buttonholes in grafts.
Conversely, the area technique, when needles are repeatedly inserted into the same general area, is explicitly not recommended because it leads to aneurysmal dilation and thinning of the overlying skin, increasing the risk of rupture and infection.
Area technique is bad, causes aneurysms.
After needle withdrawal, gentle direct pressure should be applied using a two-digit technique. Clamps are highly discouraged. If there's prolonged bleeding or difficulty achieving hemostasis, that's often a red flag for venous outflow stenosis.
Gentle pressure, no clamps. Prolonged bleeding suggests outflow stenosis. So careful cannulation is a major preventive measure. What about surveillance during hemodialysis sessions? What tools do you use to detect problems early?
During dialysis, we use flow measurement methods like the ultrasound dilution technique, UDT, or direct DUS. The guidelines recommend surveillance by flow measurement monthly for AVGs and every 3 months for AVFs.
Flow measurements are key for surveillance.
These measurements are essentially an early warning system. For example, if an AVF's blood flow drops below 500 milliliter, angiographic assessment should be considered. For an AVG, if flow drops below 600 milliliter, it's associated with stenosis. Or if the flow decreases by more than 33% from its baseline, it's a cause for concern.
Thresholds like 500 for AVF, 600 for AVG, or a 33% drop trigger investigation.
Interestingly, pressure surveillance using venous pressure measurements, which some centers use, is not considered a reliable indicator of stenosis on its own, and intervening based solely on this is not recommended by the guidelines.
Venous pressures alone aren't reliable for stenosis.
Of course, unexplained decreases in dialysis efficiency, like a drop in KTV or urea reduction ratio, can also be a strong clue to venous outflow stenosis. Overall, while flow surveillance helps reduce thrombosis for AVFs, studies haven't consistently shown it reduces thrombosis or improves survival for AVGs.
Flow surveillance helps AVFs. Less clear benefit for AVGs. This really sounds like a team effort. What's the role of the entire healthcare team in all this?
It absolutely is a team effort, and that's our final crucial point. The multidisciplinary team, MDT approach, and the vascular access nurse. A multidisciplinary team including nephrologists, surgeons, interventional radiologists, and especially dedicated nurses is absolutely crucial for optimal care.
The NDT is vital.
The guidelines even recommend the appointment of one or more specialized vascular access VA nurses to improve patient care and outcomes. These VA nurses play a pivotal frontline role in planning, patient education, the actual cannulation process, ongoing monitoring, data collection, and coordinating care with surgeons and the dialysis unit.
The VA nurse is key.
They are often the unsung heroes who significantly extend the life of a vascular access and, crucially, help reduce reliance on central venous catheters.
So what does this all mean for you, our listener? It means the longevity of a vascular access isn't just about the initial surgery. It's a continuous, vigilant process of meticulous care, early detection of issues, and timely intervention.
Constant attention.
The idea of the vascular access nurse being that frontline experienced guide really highlights how a dedicated, integrated team truly makes all the difference in a patient's journey to consistent, life-sustaining dialysis.
Absolutely. Now let's bring it back to our patient and put this knowledge into a practical scenario. He underwent successful creation of a new brachiobasilic AVF. However, 3 weeks later, he presents with a painful, swollen arm. What is your differential diagnosis, and how would you immediately manage this scenario?
Okay, this is a classic high-stakes scenario that requires rapid assessment and intervention. For a patient 3 weeks post-creation of a brachiobasilic AVF, presenting with a painful, swollen arm, my differential diagnosis would primarily include, let's see.
What jumps out first?
1. Early thrombosis. This is the most common. Our patient's history of failed accesses and diabetes makes him inherently high risk for clotting. The arm swelling might not be as pronounced as with other causes, but pain would be significant, and the thrill and bruit would be absent or dramatically reduced.
Thrombosis high on the list.
2. Early onset VA-induced limb ischemia, Steele syndrome. Brachiobasilic AVFs are upper arm fistulas, and as we discussed, they carry a higher risk of Steele. The painful aspect, especially if it's rest pain or cold sensitivity, combined with the swollen arm and signs like pallor or coolness of the hand, are classic indicators.
Steele is definitely possible with a BDAVF.
3. Venous outflow obstruction, early non-maturation stenosis. The swollen arm points very strongly to this, as it indicates venous hypertension. The fact that the fistula was successfully created suggests patency. But if blood can get in easily but can't get out easily, it backs up, causing swelling. This could be due to an intrinsic narrowing.
Outflow blockage causing the swelling. Very likely.
4. Infection. While less common for autogenous fistulas this early compared to grafts, it's always a possibility, especially given his history in diabetes. I'd look for accompanying signs like erythema, warmth, purulent discharge, or systemic symptoms like fever.
Can't rule out infection.
5. Significant postoperative hematoma or fluid collection.
Yeah.
Could cause swelling and pain, though maybe less likely 3 weeks out, unless something new happened.
Less common, but possible.
6. Ischemic monomelic neuropathy, IMN. Less likely to be just painful, swollen arm, as it typically involves sensory and/or motor deficits, but crucial to exclude given the severity.
Always keep IMN in mind, even if less likely here. A very well-structured differential diagnosis. Now, describe your immediate management steps for this patient. What's the very first thing you're doing?
My immediate management would begin with a rapid but thorough clinical assessment, urgent physical examination, inspection for redness, swelling, palpation for through quality, continuity location. Absent, pulsatile, check arm temp, cap refill, distal pulses, any sensory motor deficits.
Hands-on first.
And a key diagnostic maneuver for suspected steel, temporary compression of the AVF. Does it improve hand symptoms?
The compression test again?
Following that swift clinical assessment, urgent imaging is the next crucial step. Duplex ultrasound, DUS, is the first line.
TUS straight away.
The DUS is essential to confirm patency, locate and quantify any stenosis outflow, juxta-anastomotic, central rule-out thrombosis, assess flow. It gives us critical real-time information on the exact cause, guiding our next steps.
So, based on the most likely findings from your assessment in duplex, let's assume venous outflow stenosis or early non-maturation is confirmed, as that's often indicated by swelling. How would you then proceed with scenario-specific management?
Right. If the DUS confirms venous outflow stenosis or early non-maturation, which is highly likely with that presentation, I would immediately refer the patient for prompt diagnosis and treatment.
Get them to intervention quickly.
The primary intervention would likely be an endovascular approach, specifically percutaneous transluminal angioplasty, PTA, to open the stenosis. This is often successful.
Balloon angioplasty first.
If PTA is unsuccessful or if the anatomy isn't suitable, then surgical revision, such as a patch angioplasty, a bypass, or even a vein transposition, would be considered. Additionally, I would strongly re-emphasize and educate the patient on arm exercises to promote maturation.
Surgery if PTA fails, and keep up the exercises.
As this can significantly aid in vein dilatation and flow.
What if the DUS shows early onset Steele syndrome, given it's a brachiobasilic fistula?
If early onset Steele syndrome is confirmed, immediate surgical correction is necessary. For severe symptoms, especially if IMN is suspected, urgent ligation of the AVF is the absolute priority to prevent tissue loss or permanent neurological damage in the hand.
Ligate immediately a severe Steele or IMN.
For less severe cases, or if the patient's anatomy allows, we might consider flow-reducing procedures like banding, diural, distal revascularization, and interval ligation, or ADI, revisions using distal inflow. These are complex techniques
Flow reduction surgery for milder cases.
designed to balance flow between the fistula and the hand.
And if it's an early thrombosis.
If early thrombosis is diagnosed, that would necessitate urgent thrombectomy, removing the clot and revision of the fistula. If an underlying stenosis is identified as the cause, it must be addressed at the same time to prevent recurrence.
Thrombectomy and fix the cause.
Ideally, this intervention should occur within 7 days of the thrombosis. A crucial point here. Thrombolysis, using clot-dissolving drugs, should not be used for early thrombosis within 7 days of creation due to the high bleeding risk.
No thrombolysis early on.
Finally, what if infection is confirmed?
If infection is the primary concern, I would immediately start empiric broad-spectrum antibiotics. If the AVF infection is localized without systemic signs of sepsis or involvement of the anastomosis, continuation of antibiotics might suffice, sometimes for an extended period.
Local AVF infection, try antibiotics first.
However, if there are systemic signs of sepsis, or if the infection directly involves the anastomosis, ligation of the AVF would be required to control the infection and protect the patient. As we discussed, for a prosthetic graft, if it were one, it would generally require complete excision.
Systemic infection or anastomosis involved ligate the AVF.
This truly highlights the dynamic nature of vascular access management. It's not a fix-it-and-forget-it situation. Problems can arise quickly, and a methodical, guideline-driven approach combined with clinical acumen is absolutely essential for timely diagnosis and intervention to save the access and, more importantly, the limb and the patient's long-term dialysis viability.
Absolutely. Constant vigilance.
And there you have it, a whirlwind deep dive into the complex world of vascular access for hemodialysis, framed by the ESVS 2018 guidelines, and a challenging clinical scenario straight out of a surgeon's daily practice.
We covered a lot of ground.
We've navigated the initial patient assessment, explored the myriad of access options, discussed how to adhere to best practice principles, and tackled the daunting list of potential complications.
Exactly. What we've discussed today forms the core of knowledge for any specialist involved in dialysis care. For those who train in this demanding field, and for any clinician managing these vital lifelines, the key takeaways from our simulated Viva can be distilled into this crib sheet.
Okay, the essentials.
First, the core principles. An autogenous AVF is always the preferred first choice. Fistula first. And, critically, avoid CVCs whenever possible.
AVF first, lying last.
For assessment. Duplex vein mapping is a universal recommendation for all patients. It's essential. And generally, the non-dominant arm is the first preference.
DUS for all, non-dominant arm preferred.
Regarding access order, follow a systematic approach. Distal to proximal autogenous fistula first, then graft, then central catheter as a last resort.
Distal proximal start line.
When it comes to complications, vigilance is key.